So any deformity which is proximal to the femoral condyle or distal to the fibular neck is labeled as an extra-articular deformity. Distal femoral deformities would affect the extension gap, and tibial extra-articular deformities usually affect both the extension and flexion gaps. So these are the basic things you need to know. So we'll discuss the corner plane deformities, sagittal and rotational deformities. The mean axis deviation should not be more than 8 millimeters for a good alignment of the total knee. If you do that, you will have difficult collateral ligament balance in flexion, and there will be marked imbalance. And here you can see there is a huge mean axis deviation and an oblique joint line. So this would lead to early failure if the deformity is not addressed. Another thing you need to understand is the closer the deformity apex to the knee joint, the larger is the effect. So this X-ray itself, explains that. Here you can see that as you go towards the joint, the resection of the distal femoral condyle is actually, hampering the attachment of the collaterals. So that is where the extra-articular deformity near the joint affects. If you do overzealous release of intra-articular corrections, it will lead to instability and flexion arc imbalances that would affect the total knee arthroplasty functionality. So this is what happens. So if there is an extra-articular deformity and you try and cut it 90 degrees to the perpendicular to the mechanical axis with an extra-articular deformity, you resect more of the distal femoral condyle on one side. It leads to lateral, laxity. To balance that, you're going to release more medially. That balances your extension gap. But you see on the flexion, it's going to open up. So you'll have flexion imbalance. So that is why, it needs to be addressed. Wang and Wang gave Wang's principle, where he said that the mechanical axis, when it's cut at 90 degrees, should not be hampering the attachment of collaterals on the femoral side. And the mechanical axis on the tibia should be actually coming through the condyles and not going out. And not hampering the attachment of the collaterals. These are the kind of deformities which should be corrected intra-articularly. If you don't do that, you will have a trapezoid gap which needs to be balanced. You also need to understand the difference between varus tibial deformity versus a valgus deformity, where a varus deformity would be actually, a higher deformity would be able to be balanced during surgery, but a valgus deformity might hamper the attachment of collaterals and needs to be addressed. So it's a little difficult in a valgus tibial deformity. Also need to understand the difference between proximal versus distal tibial deformity. So the proximal tibial deformity would have a greater MAD, mean axis deviation, as compared to a distal deformity. But there is also a catch. If the tibial deformity is too close to the ankle joint and there is a joint line obliquity at the ankle, that needs to be addressed first before the ankle, before the total knee arthroplasty. So the management is simple. You can do a primary total knee arthroplasty with intra-articular correction, a simultaneous corrective osteotomy plus total knee, and a stage corrective osteotomy with the total knee arthroplasty. But when to do an intra-articular correction? If the deformity is less than 20 degrees in the femur or less than 30 degrees in the tibia and the cora is outside of the metaphysis. So that is an important point to understand. So this is a straightforward proximal deformity where you can see the mean axis deviation was more than 8 millimeters, but it could be corrected because the effect of the deformity was not much and intra-articular corrections could suffice. Mid-shaft deformity done total knee arthroplasty using navigation, a good achievement, alignment achieved with the intra-articular corrections. A distal femoral deformity, single stage intra-articular correction can be achieved if the angle is less than 20 degrees. This is an example. Now this patient also had a hyperextension deformity on the sagittal plane, so it's a biplanar deformity. It was still managed with navigation and the outcome is fine. This is almost a 10-year-old case when navigation had not come percolated into our practice, and this is a patient who had twice failed attempts at nail removal, and ultimately I used eye assist and a total knee arthroplasty was done without removal of the nails. So that is how technology helps in these extra-articular deformities. Another case, single stage intra-articular deformity, tripelvic deformity. She had rotational also, sagittal plane deformity in the femur, malunited fractures in the proximal tibia, and the deformity was almost 20 degrees on the tibial side with a valgus. I could achieve intra-articular corrections using navigation. This is the final outcome. The patient is doing well at 4 years now. Now, when to do a single stage osteotomy with a total knee arthroplasty? The benefit is that it gives you single surgery, single recovery, shorter operative time, and it's cost effective. Perform the osteotomy first, stabilize with a nail or plate, and replace later. So this is an example where the deformity in the tibia is almost 24 degrees, malunited fracture. It has been corrected with a plate, and a long stem has bypassed the fracture and the fracture united. When to do a stage correction with a total knee arthroplasty? If you have a multiplane deformity, the deformity is very close to the knee joint, and there's a large leg length discrepancy that needs to be addressed. So advantages are it gives you flexibility in surgical planning, shorter operative times, and subsequent use of standardized implants. Two-stage extra-articular correction in a total knee arthroplasty where nailing was done, the nail removed, the fracture united, and the straightforward standard total knee arthroplasty done. 60-year female, DHS done somewhere else. You see a curve in the tibia. Someone did Sikh kebab osteotomy and a nailing, and then she came to me and a total knee arthroplasty was done with a long stem. The osteotomy had already united. In the sagittal plane, if you have a flexion less than 10 degrees of and less than 20 degrees of recurvatum, it can be addressed. But if there is a higher deformity, you need to do an osteotomy, put in a supracondylar nail, a open wedge supracondylar osteotomy was done. The fracture reduced and grafted, and the total knee arthroplasty done in the patient. This is another example of a recurvatum where you can see the extra-articular deformity could be managed intraoperatively with navigation, and the patient is doing fine. Rotational deformities up to 10 degrees, they can be corrected intraoperatively. You can dial up to 3 degrees of internal rotation in an external rotation deformity, and up to 8 to 10 degrees of external rotation in an internal rotation deformity. Beyond this, notching would happen. Wang recommends a two-stage correction. So the take-home message is intra-articular correction for a mild deformity, osteotomy plus total knee arthroplasty for a very large deformity as recommended, a two-stage correction for a multiplane 3D deformity with rotational deformities. Navigation and robotics are very helpful. Thank you.
Thank you, Dr. Meena.